right. My name is Stephanie Luca. I am an emergency physician working in Richmond, Virginia. I work at both a level 1 trauma center as well as 2 different freestanding ERs where I'm the only provider there when we have just 12 beds and a very small team. I'm also the mother of 2, so I guess somebody thought that made me qualified to talk about questions. But first, let's look at some of our objectives for the talk today. We're going to review the relevant anatomy and physiology of pregnancy. We're going to talk about general approaches to the injured pregnant patient in particular. And we're going to do some case reviews. We'll do 2 OB-specific cases, and then we'll also follow that up with 2 medical cases as well towards the end. So pregnancy, I can tell you, could be a horrible, could be a wonderful, terrifying disease state that affects almost every organ system and has a not so insignificant morbidity and mortality associated with it. So we're going to talk about these anatomic changes that happen to critical organ systems. So as far as respiratory changes, one of the things that happens is your functional residual capacity drops by about 20%. And if you recall, your functional residual capacity is that extra room you have. So if you decide instead of taking your normal breath that you're going to take the deepest breath possible that you can take, it's that extra room that disappears in pregnancy and gets diminished. You also are going to see an increase in oxygen demand and consumption, as well as an increase in respiratory rate and tidal volumes to help match that increased demand. And all of that is going to add up to a decrease in the safe apnea time. And so I think understanding the respiratory physiology of pregnancy is critical in caring for these injured pregnant patients, because even before the uterus becomes large enough to have a direct mass effect on the diaphragm, the patient's going to develop changes necessary to provide oxygen to the fetus as well as herself. And most critically for you, a pregnant patient has, as we said, that decreased residual capacity, but that along with they're also going to be experiencing some airway edema due to the vasodilation. They have increased estrogen as a result of pregnancy, and that's going to lead to potentially some airway swelling. As well, the weight of the breast tissue on the chest wall is going to help potentially decrease the ability for easy compliance and thoracic expansion. And all of that adds up to the fact that every obstetric intubation should be considered a difficult intubation. When we look at the cardiovascular system, when the patient stands up, the cardiac output goes up by 20%. In a supine position, the cardiac output actually decreases by 30%, and that's all related to the compression on the vena cava, and also the reason that we tend to rotate these patients on to their left side. You get an increase in heart rate of roughly 10 to 15 beats per minute, and a relevant decrease in blood pressure of 10 to 15 millimeters per mercury. This here is actually a CAT scan, and what the big blue arrow is pointing to, believe it or not, is a baby. You never want to be the doctor that diagnoses pregnancy with a CAT scan. It's kind of poor form. So as far as the changes to the blood or the hematologic system, the red blood cell volume does increase by 25%, but the plasma volume, so everything else in the blood, is going up by 40%. And so what you get is a relative decrease in hemoglobin, resulting in an anemia of pregnancy, which is normal at baseline in pregnancy. You also are going to see an increase in the prothrombotic factors, so the clotting factors, and part of that is protective for mom, right? There is a lot of normal blood loss associated with pregnancy, and the body ramps up those prothrombotic factors in preparation for delivery so that mom hopefully does not hemorrhage to death. But that can work against you if you're dealing with a trauma patient that's bleeding for totally different reasons. And pregnant patients could lose up to 2 liters of blood before any change in vital signs. But the fetus could be in shock. So just keep all of those things in mind. Other changes, this is me, by the way, when I was pregnant, you're going to get relaxation of the lower esophageal sphincter, and delayed gastric emptying. And that is relevant when you go to intubate these patients. They are going to be a higher aspiration risk. The pubic bone is going to widen 4 to 8 millimeters. A lot of times, if people are looking at x-rays in the pre-hospital setting, they misdiagnose a pelvic fracture because the pelvis looks wider, but some of that is just normal pregnancy. You're going to get vascular congestion. You have increased creatinine clearance. So creatinine is a measure of kidney function, and your kidney is doing more work, circulating more blood, and as well, there's more blood circulating through the liver. So let's do our first kind of practice question here. You have a 38-week pregnant patient who's hypoxic after an MVC with absent right-sided lung sounds, a barcode sign on lung ultrasound. Don't worry if you don't know what that is. And tracheal deviation to the left. Anterior chest decompression fails. Where should you try next? Do you want to go to the left second intercostal, the intersection of the right inframammary and anterior axillary line, the right third intercostal, the right second intercostal at the mid-axillary line? And if you said C, right third intercostal space at the anterior axillary line, so essentially you're going down and over just a tad, you would be correct. You will still be safe and nowhere near the uterus at that point. All right, so how do you palpate for gestational age, right? How many times you get to a patient, they're unconscious and they can't tell you, or they have no idea how pregnant they are. Remember, first trimester, really the pregnancy is staying intrapelvic. So a lot of times you can't feel anything till at least the end of the first trimester. 20 weeks, the landmark is the belly button. You should be able to feel the top or the fundus of the uterus there. And then roughly a centimeter per week moving upward. And so at 36 weeks, the uterus is really up at the lower margin of the ribs. But at 40 weeks, you'll see on the diagram there, it drops down again. That's a result of when baby actually engages and drops down in the pelvis, that fundal height can be felt a tad bit lower. So I think we just covered our first objective of reviewing the A&P. Let's talk now about how do we assess these patients. So whether you took ATLS or PTLS or IHTLS or, it really they all are very similar. But there's a primary survey, right? We're assessing for life-threatening injuries, A, B, C, D, E. And then you have your secondary survey, right? This is not a new information. But I like to think of it as you're doing your typical primary survey for mom, but then you are also doing an abdominal exam that will help you get a sense of the ABCs for the fetus. So that is looking at abdominal tenderness, at the fundal height. Can you palpate a uterus? Are there contractions happening? Is there vaginal bleeding or loss of fluid? What is the fetal heart rate? You could do that with an ultrasound, or if you happen to have a Doppler. Is there a bulging perineum, or is there crowning that's happening? And then on your secondary survey, that's your typical head-to-toe frisk that we all do on every trauma patient. So really, it's this middle part here that you add and insert into your assessment of a critical trauma, pregnant trauma patient to help make sure you're not missing anything. All right, so what drugs are absolutely contraindicated in resuscitation of the critically injured pregnant patient? As always, your first priority is to mom. While pregnancy is a relative contraindication for the use of some of these drugs, including vasopressors, NSAIDs, ketamine, others, there are no absolute contraindications when it comes to managing life-threatening injuries to mom, right? Because if mom doesn't survive, fetal mortality is nearly 100%, right? So your priority is resuscitate mom, and especially if you're, looking at the only other option is death, it is certainly worth trying some of these medications. Okay, so that's how I approach things. Let's do some case studies. So case one, you respond to a local fire rescue who's on scene of an MVC. Your patient is a 28-year-old female who is a restrained driver of the white car. She's alert but not oriented on your arrival. Her husband is on scene and tells you she is pregnant but has had no prenatal care. All right, so on exam, her skin is cool. She's got a seatbelt sign both over the chest and over the abdomen. She's tachycardic. She's having severe abdominal tenderness. You can appreciate no palpable fundal height. Her GCS is 12 with a non-focal exam, and she's got no vaginal bleeding or loss of fluids. But on her vitals, you can see she's profoundly hypotensive. She's tachycardic. She's tachypneic, and she's requiring a non-rebreather for an SpO2 of 98%. So what's on your differential diagnosis? Meaning what are the possibilities that are going on here, and what do you kind of need to be on high alert for? So this could be a uterine rupture. This could be like a stable pelvic fracture, and maybe she's hemorrhaging internally. This could be a solid organ injury, a good old spleen or liver lac, or maybe this is even an ectopic pregnancy. Who knows? Maybe she was having pain when her ectopic ruptured, and that's why she crashed the car, right? We don't really know without that good prenatal history. So what are you going to do immediately, right? She's clearly needs resuscitation. This case in particular happens to be one of uterine rupture. You are going to see profound shock in these patients. There, as long as the patient is awake enough to tell you, will be abdominal tenderness. You likely will feel what's called a non-palpable fundus. So, usually your uterus is firm, round, and really well defined because you have the amniotic sac and it's filled with fluid. Well, once you rupture and disrupt that integrity of the sac, the fluid spills out, blood spills out into the abdomen. Sometimes baby will exit the uterus internally. And so you really sort of lose that structure to the uterus. And sometimes you can't really palpate much of anything, or you palpate and it's very confusing. This is nearly always fatal to the fetus. Unfortunately, there is a 10% mortality associated for mom, and this happens in about 0.6% of blunt abdominal trauma. The treatment is going to be the same as any treatment for internal hemorrhage. ABCs, give blood if you have it, put your patient in left lateral position. In your region, if you do happen to have an OB alerting, in Virginia, we have pre-hospital OB alerts where EMS folks can call ahead, and in the ED, we'll assemble the ED team, the OB team, if needed, the NICU or the PEDS teams to be waiting in the ER. And sometimes these patients will go straight to the OR if we know ahead and the clinical picture warrants it. So this particular case happened to be due to was a uterine rupture due to improper seatbelt positioning. Just kind of an FYI. When you are pregnant, you want to use your seatbelt, not like you see on the left where it's riding high, like falsely high over top of where baby is. You want to let it rest comfortably, or it naturally falls down on the hips there to avoid impact to the uterus during a crash. All right. Another quiz. The most prevalent form of trauma experienced by pregnant patients is domestic violence, MVCs, falls, or penetrating trauma. If you said domestic violence, you are correct. And unfortunately, you're correct by a long shot. So this is a study in American Journal of OB-GYN looking at incidents per 100,000 live births of domestic violence versus MVCs versus falls versus penetrating trauma. And clearly, domestic violence is the biggest threat to our pregnant patients. So that's a segue into case number 2. You are dispatched on an interfacility transfer for a patient with severe vaginal bleeding after being assaulted by her partner. She's 27 weeks by last menstrual period, and she's gotten 2 units of red blood cells and 2 units of fresh frozen plasma prior to you getting to her. On exam, her skin is cool. She has bruising to her abdomen and her face. She's tachycardic. Her abdomen is tender, gravid. You can palpate the fundus in this patient 3 centimeters above the umbilicus, so that's about 23, 24 weeks. Neurologically, she's obtunded. Her GCS is 7, and she does have vaginal bleeding. Her vital signs, again, hypotensive, tachycardic, tachypneic, requiring a non-rebreather. So what's on your differential diagnosis this time? I think just like last time, placental abruption we need to think about, but let's add placenta previa. uterine rupture. This could be the start of labor. Maybe there was vaginal trauma due to rape, given kind of the terrible circumstances. But your immediate interventions, I don't think anybody would argue this patient's going to need pretty immediate airway management since she's has an altered mental status and requiring non-rebreather. She's going to need volume. She may even need pressors. We got to manage a lot here. So this particular case is a placental abruption. We see this in 1 to 5% of minor abdominal trauma, so injury severity scores of less than 10, and 20 to 50% of major abdominal trauma. Only 70% of these patients will have vaginal bleeding, and if you remember this little diagram here, the baby on the right is the complete abruption with concealed bleeding, right? So this is where the baby itself, usually the head, is blocking the cervix. So even though there's bleeding within the uterine cavity, that blood is not escaping because baby's basically blocking the exit hole. And so these are 30% of cases. So don't be reassured by no bleeding is the take home there. There's going to be uterine tenderness, increasing fundal height. And again, you can see in sort of the picture on the right why as more blood flows and fills the uterine cavity, why you could get an expansion of the size of the uterus itself and increasing fundal height. You can pick up on contractions or maybe uterine tetany. And this is going to carry a 12% mortality rate versus that 0.8% overall maternal mortality rate that we see in the U.S. So treatment is going to be the same as any hemorrhage. Blood out, needs to come back in, but this is not the same as postpartum hemorrhage, right? We use a lot of medications in the hospital for postpartum hemorrhage, like Pitocin. There's really not a role for those types of medications. It's a different pathophys, but there's probably a role for vasopressors if they're needed after resuscitation. And again, think about your OB alert, because again, this is a patient that could potentially go straight to the OR. So another self-quiz. Besides exsanguination, what are some of the other life-threatening complications of placental abruption? We're going to talk through a few. All right, so DIC, and that's due to massive hemorrhage and the prothrombotic nature of pregnancy itself. You might see an unfortunate amniotic fluid embolism, an AFE, which is like a PE, right? You're getting an embolus to the lungs, but can also cause a sepsis type state because the amniotic fluid is very inflammatory, right? It's coming from inside the uterus and it's foreign, if you will, to mom. And so the immune system revs up when this kind of gets released. And so if you see a patient that's sort of PE picture plus sepsis in a pregnant patient, think about an AFE. And then also, of course, preterm labor is potentially an issue. We can see that in up to 25% of blunt trauma. So case 3, you are emergently transporting a 33-week pregnant patient who suffered crush injuries to both legs with arterial hemorrhage. Tourniquets are placed, but blood is unavailable. She's unconscious, markedly hypotensive and tachycardic, without, though, any signs of active bleeding. Your tourniquets were effective. You were unable to oxygenate and decide to intubate, after which she promptly goes into asystolic cardiac arrest. Bummer. All right, so some of you guys may be familiar with a procedure called the perimortem C-section, and basically this is a intra-arrest. So while you're doing ACLS and coding this patient, you're also performing a C-section. This is not done by nurses or EMS personnel. This is a physician skill. But I want you to know about it because there is a chance that maybe you're in an ED when this happens and you might be asked to assist. And I also don't like this name very much because I don't think it really focuses on what the true goal of the procedure is. I like resuscitative hysterotomy more because, right, the idea is we're doing a procedure that's not really baby focused. The goal is to restore the hemodynamics and save mom in the hopes that, and hopefully we could maybe save baby. So what happens is when you take the baby out and take the placenta out, you're relieving that IVC compression, and you're also removing that low resistance placental vascular bed. And you're starting you're starting the reversal of that vasodilatory process that exists in pregnancy. Immediately, you get a 60 to 80% increase in cardiac output. And the science behind this is pretty good. There's a 30% maternal survival and 50% fetal survival. And in one case series, 34 of 38 infants survived, 7 of which were after 15 minutes of CPR. So this is not one of those, I mean, it's a heroic measure, but it's not, sometimes without its successes. So it's worth knowing and worth doing. But in reality, this is a clinical, legal, emotional disaster for everyone involved, for the family, for the patient. Even if they survive, sometimes they lose the child. It's emotionally the pucker factor on these things is incredible. So it's stressful for all the care providers as well. But like I said, I want to talk you through the steps of resuscitative hysterotomy. Not that you're ever going to be doing one, but trust me, if I'm working in the freestanding ER and you come to me for stabilization because your patient is sick as snot and, peri-arrest or just arrested, as you were driving by and you have to veer over, I'm going to ask you to stick around to help, because we're about to have not one, but 2 critically ill patients, or maybe even critically ill megacodes. So you start CPR and you immediately start grabbing all of your equipment you're going to need for this procedure: scalpels, incubators, you name it. There's a lot that goes into this. We're going to displace the uterus to the left. We're going to pull it that direction, not push it. And then while we're doing CPR, if we're not getting ROSC through traditional ACLS after one round, we're going to do a vertical, we being me, a vertical skin incision from basically right at the subxiphoid space all the way down to the pubic bone. And then gonna dissect down, open up the peritoneum, open up the uterus, get the baby out, get placenta out. And then I'm not stitching mom up. What I'm doing, we're going to be packing a bunch of gauze, a bunch of towels, 4x4s, whatever we have, to try to get some hemostasis, quick clot, you name it, whatever we have. We're going to pack that uterus full to get some direct pressure and hopefully get some hemostasis. But like I said, outside of the paramedic scope of practice, and I know of at least 2 cases where paramedics have lost their state licenses and been exposed to personal liability after performing this procedure pre-hospital, even after they obtained orders from online medical direction to do it. So do not do this. It's not really defined in the nursing scope of practice either. But like I said, you might find yourself in an ED with a coding pregnant patient, and especially if it's a understaffed or freestanding ER, you might be asked to help. And so I want you to be prepared. Just have at least some familiarity with what's going to go down. All right, so I think we achieved all of those objectives. Now I want to segue onto OB medical emergencies. We're going to talk about the spectrum of preeclampsia and eclampsia. We're going to do a case study, actually 2 case studies, and we're going to talk about HELP syndrome as well. All right, so eclampsia, what is it and why does it happen? This picture here is actually a plastination of the placenta, so you can sort of appreciate how vascular it is. But eclampsia is a disorder of widespread vascular endothelial damage. Your endothelial cells are the ones that line your vessels. And so that they become dysfunctional and you get a lot of inflammation and vasospasm in the vessels. And this happens after 20 weeks and somewhere up until 4 to 6 weeks postpartum. The vessels get damaged, they become leaky, and in mom, that sort of manifests itself as edema. And for baby, the placenta is also getting damaged. And what happens there is that ends up inhibiting blood flow to the fetus, and so you get intrauterine growth restriction, or IUGR. So both mom and the fetus are affected by eclampsias. So, little quick quiz. Preeclampsia is defined by which of the following in a pregnant patient over 20 weeks gestational age? All right. If you said hypertension and proteinuria, which is protein in the urine, you are correct. All right. So high blood pressure, and we're going to talk about the number parameters for this in a second, and protein in the urine. Now, I don't know. I can't imagine most of you guys are, collecting urine samples and dipping urine in the back of the ambulance. But, certainly you may pick up an interfacility patient who's already carrying this diagnosis. Edema used to be, interestingly, in the criteria. So if you had hypertension plus edema, that was preeclampsia. But what we found was edema is so nonspecific and just a normal part of pregnancy for many women that we were overdiagnosing it. So that edema is no longer part of the diagnostic criteria. But there are, just so you know, levels of preeclampsia. There's mild, severe, and then eclampsia. And I think of those along a spectrum. The blood pressure parameters you see at the top there for mild, you have to have either systolic over 140 or a diastolic over 90. One of those could be normal and the other elevated, and it still qualifies. Same thing with severe. You can see it's 160 over 110 and eclampsia 160 over 110. And some of the differences here, in mild pre-E, you still have normal serum creatinine, so your kidneys are functioning normally. But in severe pre-E, you see a rise in the creatinine, which shows us that the kidneys are under stress and are having difficulty. You also can see symptoms like pulmonary edema, decreased urine output, IUGR, headaches, visual disturbances, epigastric pain, sometimes HELP syndrome. But the real thing that distinguishes severe pre-E from eclampsia is going to be the mental status, the seizures, coma, disorientation, AMS. If your patient, has a blood pressure that's elevated and is altered, now they're meeting criteria for eclampsia. Risk factors for eclampsia and preeclampsia, nulliparity, which means the patient's first pregnancy, preeclampsia or eclampsia in a prior pregnancy. If they are advanced maternal age, which is greater than 35 years old, if they have a family history of preeclampsia or eclampsia, or in this pregnancy, if they have one of three things, if they've been diagnosed with a placental abruption, IUGR, or fetal demise. Sometimes, unfortunately, preeclampsia can lead to any of those three things, and sometimes we find one of those three, and then we go investigating for a cause and find out, the pressures are high. There's protein in the urine. There's actually preeclampsia going on in the background. So treatment comes into play in the pre-hospital setting when the patient meets eclampsia. And so the mainstay of treatment is going to be magnesium sulfate. You can give 2 to 4 grams IV over 5 to 10 minutes, preferred if you could give 4 grams. If you don't have an IV, you can give it IM. You draw up 1 gram per dose and you put it in separate locations on the body. If they're seizing, midazolam is a great drug. You can give it intranasal, IV, IM. Diazepam is definitely a reasonable alternative if you don't have midaz. But you definitely want to take this patient to an OB-capable facility because ultimately what they're going to need is delivery of the fetus. Mom is not going to get better on her own. The magnesium and even, blood pressure control medications are just sort of symptomatic treatment. You got to fix the underlying cause, which is pregnancy. All right, so case study 1, unconscious in the second trimester. All right, so this is a real case that I was a part of. You go in a scene flight. There's ground EMS on scene. You come across your patient's a 25-year-old G1P0 at about 6 months gestational age. It's been a normal pregnancy so far with no prenatal concerns. She had a syncopal episode at home and on EMS arrival was found to be postictal and disoriented. So on her exam, her heart rate is tachycardic. She's hypertensive, and her SATs are 83%. Her mental status is waxing and waning. At moments, she's entirely unresponsive. Other moments, she sort of wakes up and is combative. She has 3 separate seizures. She's posturing. None of it's good. It's all bad. Her skin is pale, moist. She has a petechial rash. Her tongue is swollen. We talked about that airway edema. She's tachycardic. She's got the gravid abdomen, and she has been incontinent of urine. So what would you do next, right? There's a lot going on here. Patient is critically ill. What would your next priority be? This particular flight crew chose intubation with a CMAC, which I wholeheartedly agree with. And now what I'm going to go through is a course of events, sort of chronologically. These first events are what happened still in the pre-hospital setting before they got to the ER. So they RSI her with ketamine and rock. Drug choice was based off of availability in the drug box, right? No hard contraindications during pregnancy if it's life-threatening. They were able to perform a successful intubation. Her blood pressure on their next reassessment had lowered, likely secondary to the medication she just got. They did opt to give her some Ativan. They initiated sort of in parallel the magnesium sulfate, 2 grams per hour, and reassessed her vitals, right? They'd made some interventions and found her blood pressure creeping back up again, but mental status and everything else essentially unchanged. They did opt to give her hydralazine for blood pressure control. And then they went ahead and called ahead to the destination, to the ED, so that the ER, the OB teams, the NICU teams could be aware of what they were bringing and could assemble and prepare adequately in the ER. So at 10:53, they got to the ER. So one of the first things I did was wanted to get a sense of, what's the urgency? How's baby doing? If baby's already gone, that changes things a little bit, right? But if baby's viable, that also can impact our medical decision making. So I used the ultrasound. This is a curvilinear probe, and just put the probe down on mom's abdomen to find baby's heart, and using what's called M mode, assess fetal heart rate. And so what you do is you turn on M mode, and it gives you this little wave pattern here. And then you take your calipers and you measure in the same spot at the start of one wave and the start of the next. And the machines are smart. They calculate it for you. So this fetus had a heart rate of 148 beats per minute, which after 12 weeks is normal, right? We want to see 120 to 160 beats per minute. So that was, considering how bad things were, that was slightly good news, right? We could have put the probe on and found no heartbeat, but so there was that. So remember, we're in the ED now. We get her started on nicardipine for blood pressure control, continue the magnesium. She stays obtunded, despite the fact that at this point it had been over an hour since she got those RSI drugs, and she's mentally doing nothing. So we opted to get a CAT scan of her brain to make sure she hadn't suffered an intracranial hemorrhage, remember, with that high blood pressure. And then at 11:30, she comes back from the CAT scanner. And so, like any intervention, you reassess your patient. But this time the fetal heart tones, the fetal heart rate, has dropped to 60 to 80 beats per minute. And OB is with me at this time doing the ultrasound. And now we're worried about a placental abruption. And so they decide to emergently perform a C-section right there in the ER. Because fortunately, at least we have the NICU at the bedside. We've basically got everything we need. So they proceed with that. They get baby out, and the NICU team begins resuscitation. They're handed a infant that's limp, pale, apneic, and pulseless. So they start positive pressure ventilation, right? This is NRP. They intubate the baby with a 2.5. The heart rate is 40 to 50 beats per minute. Remember, in PALS, in NRP, you want to see a heart rate over 60. Anything less than that is insufficient. So they started CPR. Heart rate remained insufficient. They gave epi. They put in an umbilical line for access and started some fluid boluses. Again, 2 minutes later, insufficient heart rate. Epi, third bolus of IV fluids. Infant remains pulseless. They give 3 more doses of epi over the next 10 minutes. Meanwhile, anesthesia is kind of over in the background with mom helping OB, who the patient who had been quite hypertensive now has delivered and her blood pressure has dropped. So they're managing turning off her nicardipine and managing sedation and all of those complex issues. But to look at the code summary for the neonate, just to kind of make sure you understand everything that was done for this kiddo. So positive pressure ventilation, proceeding to intubation. They had good capnography, but really the highest SATs were 20 to 50% throughout the entire resuscitation, so clearly not sufficient. We threw the kitchen sink of medications at this poor infant, 7 doses of epi, calcium. We were giving normal saline. Baby was getting blood transfusions. But despite all that, APGARs were as low as they could have been, 1, 1, 1, and 1 at 1, 5, 10, and 15 minutes. Baby got 30 minutes of solid CPR and chest compressions. But unfortunately, despite all those efforts, time of death for infant was called at 12:17. And not even 10 minutes later, you can see mom's vitals were reassessed. And now look at her blood pressure, 118 over 84. So just like that, not on any blood pressure controlling medications. So mom gets admitted to the ICU, and myself and folks from the NICU and OB teams go and debrief the family, because mom at this point is intubated and sedated and has no idea what's going on. But mom gets extubated the next day, and she's sent home actually on hospital day 5, which is pretty good considering how sick she was and everything that went down. And the last I looked and checked on her in chart review, she was on birth control, doing well. Like, certainly, some mental trauma from everything she went through. Not ready to try again, but all things considered, doing about as well as you could expect in a situation like that. So that's case 1. I'm going to segue quickly into case study number 2. This will be our last one for the session: headaches and hypertension in the 3rd trimester. So you get called for a patient who's having severe headaches. She's had worsening headaches for 1 week, and where Tylenol used to be effective, it's stopped working a couple days ago. She also complains of increasing fatigue and dyspnea on exertion. She's having increasing lower extremity edema and has noted a spike in weight gain. When you take your detailed history, you find out she's a 38-year-old female. She's a G1, and you'll see the P here is kind of extended. This is the TPAL. So that's the first 0 is term pregnant, term deliveries, preterm deliveries, abortions, meaning elective abortion or miscarriage, and living children. Okay, so this is a first pregnancy. She's 32 weeks and 3 days by an OB ultrasound. This was an IVF pregnancy. She has no medical history, no surgical history, no allergies. She takes a prenatal vitamin and Tylenol is needed. And socially, she's non-smoker, no alcohol, no drugs. She does work in healthcare. And this is all pre-COVID. And her vitals: she's bradycardic, she's hypertensive, 162 over 105. So if you recall, that's going to place her, shortly we'll show, but that's going to place her in the severe pre-E category, tachypnic, satting well with a GCS of 15. And she tells you, oh, by the way, because I work in healthcare and I was kind of worried about what might be going on and thought, this might be, I'm a little bit worried about preeclampsia. I dipped my urine on my own, and it has 4+ protein in it. So in physical, we talked about vitals already, but she's anxious and worried, right? Her skin, she's got spider telangiectasias. I'll show you a picture of those in a second. She's bradycardic. She's got a gravid abdomen that's non-tender and has 2+ pitting edema to the knees. And this is what a spider telangiectasia looks like. You probably recognize these. We see this more commonly probably in our alcoholic patients or liver failure patients. You see these on the skin whenever there is increased estrogen. You get that vasodilatation and leaky capillaries and makes sort of this spider mark. So if you see this on a patient, you don't know much about them, think about either pregnancy or liver disease. And like I said, because of her systolics that were over 160, this lands her in the severe pre-E category. Okay, but unfortunately, what you can't see on physical exam, and what's also very concerning going on in the background, is something called HELP syndrome. And so this may seem familiar. It is in like the paramedic textbooks, but we don't talk about it often. HELP, fortunately, is an acronym standing for hemolysis, elevated liver enzymes, and low platelets in pregnancy. I will say the disease process is poorly understood. Some folks in the OB world think of this as like a severe form of preeclampsia, but that's debated. But what we do know is it stems from abnormal placentation. So when the placenta forms and attaches and decides where it's going to settle, that process is abnormal in some way. And what happens is you get a lot of resulting vascular inflammation. We also know that HELP has more effects on the liver and the coagulation system than preeclampsia itself. So things to keep in mind. Very important is that high blood pressure, hypertension is not required for someone to have HELP syndrome. In fact, 15 to 20% of women who have HELP have normal blood pressures. But we care because there's a significant risk of hepatic infarction, hemorrhage, or rupture. Imagine rupturing your entire liver. What happens, right? It's an organ that's entirely full of blood and blood vessels. And so if that happens, your patient is going to present looking like a hemorrhagic shock. So how's your patient going to look? How are you going to pick up on this diagnosis? You're going to suspect HELP in a pregnant patient who's greater than 20 weeks complaining of any of the following symptoms. So protein in the urine, you may or may not know that information. Hypertension, remembering that not always is it there. Right upper quadrant or epigastric pain, nausea and vomiting, headaches, visual changes, and even jaundice. And unfortunately, there are no pre-hospital treatments for this condition, and unless they meet the criteria for eclampsia, then you can go down that treatment pathway. But ultimately, the treatment for HELP syndrome is going to be delivery of the baby within 48 hours. So just because I think it's kind of interesting, I wanted to show you some of the lab work associated with this particular patient. AST, ALT, the dark blue and green are liver enzymes, and then the PLT are platelets. And so we said this is a condition in which you start to see elevation of liver enzymes and low platelets. And so this patient had some early lab work where things were going okay, but then when they presented on this particular occasion feeling quite sick, we see that the AST, one of the liver enzymes, has jumped up pretty significantly, and the platelets are even downtrending a bit. And so this patient's OB team basically said, we need to induce you, and you need to have a baby in 24 hours. 48 hours, or else you're going to need to have a C-section, which is scary, right? She's 32 weeks along. And so this patient was actually me on my first pregnancy. It'll be 4 years in February. I was 32 weeks and 3 days and found out that one of the rare diseases that I learned about in medical school was happening to me, and that I was going to have a NICU baby and have a preemie and all that came with that in less than 48 hours. And that was really scary. But just to look back, it's a good thing that they made that decision. You know, the doctors were right. I'm glad I listened to them, because even after we made that decision to induce, within the next 12 hours, just kind of waiting for the induction medications to take their effect, my liver enzymes and shot up, and my platelets continued to go down. So things got worse before they got better. But they did eventually get better. And they went back to normal within just a couple days, right? So based on this chart, I think it's fun to look and kind of guess when delivery happened based on when things got better. And my daughter, if you guessed February 12th, she was born at 10:23 in the morning on February 12th. So you can see that basically as soon as the baby came out, things really started to improve. It was pretty immediate, just like that first case study we talked about, where after baby came out, blood pressures basically went back to normotensive. So that was us. We had we spent Valentine's Day in the hospital, which was interesting. So, but the takeaway points I want you to remember for eclampsia: manage those ABCs, reach for your magnesium when you need it, reach for the benzos, and control the blood pressure. But ultimately, baby has to come out. For abdominal pain in a pregnant patient over 20 weeks, remember HELP syndrome, right? Especially if you see shocky vitals, abdominal pain, this could be liver hemorrhage, liver rupture, liver infarction. Ultimately, both of these conditions ultimately are going to require delivery. And so when you're coming up with and deciding on your transport destination, consider the need for neonatal services. I can't stress to you enough how stressful these situations are for moms, babies, and families, partners. But it becomes even worse if mom is separated from baby and dad has to go between two different facilities. So if you are closest to something with a NICU, definitely opt for that as your preferred destination of choice. All right, so that is all I have for you guys today. Thanks for inviting me to participate in Refresh 2021, Rob, Lawrence. I always owe you one. And thanks for you guys for tuning in and being interested and doing everything that you do during this pandemic. I am always happy to talk about stuff offline after the fact. You can tweet at me. I'm Steph Luca MD on Twitter. Or, if you have more questions, you want resources or want to know some of my references, you can please feel free to email me at stephanie.luca@vcuhealth.org, and I will get back to you as soon as I can.